Hello. So,
I'm not ready yet.
whenever we start the abdominal exam, it always starts the same way. So, on this OSCE sheet, you'll see that you introduce yourself. So we've already been through all that, so I won't go through all that again. You explain what you're doing to your patient. You wash your hands, and so the whole time we're going to be. This exam especially, the eye exam is another one where you have to communicate clearly with your patient. So give instructions. And then I'm going to drape, which I need to grab a drape. And then work on that. Oh, I'll have to find them. Sorry, for the purpose of the recording, I'll find one in just a minute. But we'll go ahead and do this and then we'll talk about draping in a minute. So, hello patient. Nice to meet you. I'm Christina Beard. I'm a PA. I'll be doing your physical exam today. Wash my hands. And so normally you'd ask your patient your historical questions right here. You talk to them about their problems. We'll kind of buzz past that and we'll just do the exam. So you guys have your checklists. What you do for the very first part, the abdominal exam almost always starts out in the supine position. So I'll ask my patient to lay back, and we'll get you comfortable because normal exam table you'll be able to pull out the extra table thingy-majigger here, but on this one, I'll make sure you want to get a little further out of your head. You notice I'm on my patient's right side, which is the typical way that you want to examine your patient. Remember though that you'll find yourself in situations to where sometimes you can't get to the right side of the bed and you have to adapt. First of all, make sure my patient's comfy. Are you comfy, sir? Being filmed and yeah. Okay, so I'm going to ask you to raise your knees up just a little bit. And does that make you more comfortable or less comfortable? That's a little bit better. Sometimes it's easier on patients' backs to do that, to raise their knees up, and it decreases the muscle tone so that you can get a better exam as well. Okay, so the first portion is the observation portion. Sir, do you mind if I lift your shirt up so I can take a look at your abdomen?
Right.
So you always ask before you move clothing, anything like that. So I'll lift your shirt up here. Okay, so the very first portion of this, and generally whenever you're observing the abdomen, the portions that you want to observe are somewhere up to about the nipple line and about down to the ASIS. Now, if you're draping your patient, what you would do is take your paper drape and you would actually place it over and tuck it into their pants if they're wearing pants. Sometimes you have a patient who's in a hospital gown and may not have anything on under that, and so if that happens, you want to drape first, then lift so you're not exposing your patient. So think about things like that before you even try to expose your patient. Okay, so observation on my patient. Now I would say that my patient, when we're talking about the abdomen, whether it's scaphoid, flat, protuberant, I would say that my patient here has a scaphoid abdomen. So that's part of my observation. It looks symmetrical. There aren't any masses. I don't see any obvious herniations on this patient at all. So that's my observation. I also look at the skin. I don't see rashes, anything like that. No surgical scars that I can visualize. So that's the inspection, the observation. Next is auscultation, and I can bring my stethoscope. Thank you. So when you auscultate, remember you always listen first before touching the belly. So notice I have not touched the belly yet at all. So, and when you auscultate, we're listening for bowel sounds. So we're characterizing them. We're saying, are they hypoactive, normoactive, or hyperactive? And then we're saying what they sound like if they're abnormal. So for instance, if they're hyperactive, you want to say, or did they sound like rushes, which is kind of consistent with a bowel obstruction or diarrhea, or is it high-pitched tinkling, which is consistent with a bowel obstruction. So those are kind of the ways that you would describe it. When you listen to the abdomen, you listen in all four quadrants, and you always tell your patient, I'm going to take a listen to your belly. You start systematically. So I always personally start in the right upper quadrant, left upper quadrant, left lower quadrant, right lower quadrant when I auscultate. while you're here, you can listen for bruits. So you listen to the abdominal aorta, and you may need to apply firm pressure before you hear it well. And you'll listen to the renals, which is usually directly lateral to the umbilicus. You'll listen to the iliacs, which is usually directly inferior to the umbilicus on either side. And then you can listen to the femoral veins, which are in your patient's inguinal area. And again, that will involve draping and moving, and I won't do that to you, Todd. So that's your auscultation. You're listening again for bruits. Making sure I'm not missing anything. Okay, so then next on your list is percussion, but I'm going to skip that because I always do palpation first, and it's just my way I do it. So, and that's fine. Remember, on the checklist, you do it the way that you feel comfortable. So remember, light palpation is generally accomplished with one hand. I'm right hand dominant, so I always put my right hand down and my left hand on top. And I'm supposed to tell my patient, I'm going to touch your abdomen. My hands are warm, my hands are clean, so that's good. If my hands were unclean, I would wash them. If they were cold, I would try to wash them in warm water, or I would do this number and try to warm them up, or this number and try to warm them up. But my hands are warm right now, so I'm okay. So I'm going to touch your belly just lightly, and you tell me if you feel any discomfort. So the purpose of light palpation, and notice I'm only pressing it down about 1 centimeter, is to assess the patient's abdomen to see if I feel any masses or any discomfort, just a light palpation. So I start and I cover almost every inch of the surface of the patient's belly, just like this. And notice I'm pressing lightly and I'm kind of moving around, covering every surface. That's light palpation. Okay? Now, deep palpation, you press a little bit lower. You go 1 inch to 2 inches with that. And this is where you're assessing mostly for pain. Now, if I were suspecting my patient to be a squirrel, maybe not telling me the truth, right? Which happens sometimes, but not all the time, so don't get jaded. It happens sometimes. I would attempt to distract my patient. So, I wouldn't really mention that I'm doing deep palpation now. I would say, so Todd, I hear you're a PA student. How's school going? How's your drive over here? How's that weather? What's your favorite movie? You know, something like this. But as I'm talking to my patient, I'm watching his face and I'm looking for any signs of pain or distress while I'm distracting him. Okay? So that way, and I've had this happen to me lots of times, as I'm distracting my patient and I'm doing deep palpation, they're fine. They're carrying on the conversation. Everything's cool. The minute I say, so tell me if you have any pain, I do the same exact exam. Yeah, and they do that. And I'm like, I just did that, you know? When you were distracted, it wasn't that big. But when I'm calling attention to it and saying, do you have any pain, all of a sudden it's a painful thing. And that's just something to note. It doesn't mean that they're, you know, here for Dilaudid only, but it's something to note. So that's just a distractor technique that you can use. Okay, so for deep palpation, again, right hand down, left hand on top. And I press fairly deeply, and again, press and sort of rock. That's right upper quadrant, epigastrium, left upper quadrant, left lower quadrant, suprapubic, right lower quadrant, periumbilical, and make sure I don't miss anywhere. And that's deep palpation, right? And that's assessing for tenderness. So light palpation, deep palpation, and then we're going to do the palpation for the liver and the spleen. Yesterday in your PowerPoint, it had fingernails up as being the optimal. That's fine. I have fingernails though, and I tend to poke and scratch my patient, so I don't ever use this technique. I actually like, and that's fine. If you like that technique, go for it. I prefer the technique where I use the side of my hand. I think that you can get more surface area that way, and I think it's a little more comfortable to my patient as well. So I find my patient's ribs. I kind of press, see how his ribs are right here? My fingers are right here. So what I do is attempt to palpate the liver. I'll have my patient take a deep breath, and I'll rock my hand under there. Yeah, not too comfortable. And then you can release your breath. And so it's not so comfortable, especially if your patient's got problems there.
Man, I hope I don't have any problems. I was uncomfortable.
And I was pressing kind of hard. Okay. It should be a little uncomfortable.
Yeah.
It should not be painful.
Okay.
We'll maybe do another evaluation on that. So then, same thing on the other side for the spleen. You go directly under ribs, take a deep breath, and I press, okay, and release your breath. I didn't feel anything. It's normal. So that's fine. Was that as uncomfortable?
No, I was uncomfortable.
Okay, you've been drinking a lot of alcohol
No.
lately, Todd?
No, it didn't hurt.
Are you ready for
Look,
lunch?
if you do it, I'll say I've never had that done before, but
That
if you
eye-opener.
do it right, you can feel it. Like, it's a little uncomfortable, you know?
Yeah,
So
yeah.
you
But-
can actually feel your liver moving. It's weird.
Yeah, so don't be shy. These are exams where you really kind of have to get in there. So don't be shy. I mean, kind of, and you'll see when you're practicing on your own exactly how much pressure to use. So that's liver, that's spleen. Okay, so now we palpate the aorta. This is a fun party trick. So what you do is you take your hands and you press both of them inside. And I generally start way out, way further than I need to. But then I inch one hand in until I feel the tap, tap, tap of Big Red on the tips of my fingers. On Todd, I feel it approximately right here. So then I move my other hand in until I feel it on the opposite side. On Todd is right here. So I would estimate his aorta size to be approximately the width of my fingers, which looks about somewhere between around 3 centimeters. You have your rulers in your white coat, so you can kind of do that as well to estimate. So that's normal. So that's palpating the aorta, liver, spleen. Let me make sure I'm not forgetting anything. Okay. There's something else with palpation that I was just thinking of. Okay, so there's special tests, which we'll move on, and then we'll come back to that. That's a palpation thing, too. Percussion is next. Percussion is always performed in all 4 quadrants. And what you do with percussion is typically, this is something that you have to practice a lot to get really good at it. But you use, if you're right hand dominant, you use your middle finger and your index finger almost like a hammer. And the wrist action here is very important. You have to have a super flexible wrist. And this is how you will want to tap. If you do this, it doesn't work. You have to tap, tap, tap. And it's that kind of motion that gets a louder sound than this motion. And then you use your left hand or your non-dominant hand as almost like a pleximeter, like a, so you will take either your first 2 fingers. I always just use my middle finger, and I very stiffly place it on my patient, like that. And then I tap, and sometimes it takes several taps before you aim right and get it, but you listen in all 4 quadrants. And I usually aim for the DIP joint. So, so you can hear that's tympanic. That's over Todd's stomach, which it should be tympanic. You should have a little gas in your stomach. That's kind of tympanic too. Hear that difference? Dull.
That's crazy.
Isn't it? Dull. Okay. I didn't hear that. I probably didn't want to.
No, it's like finding studs in a wall.
Exactly, finding studs in a wall. There you go. So tympanic, dull. See? Kind of cool. So practice that, get it. That's percussion.
What do they signify?
Tympany signifies air. Dullness signifies solid or tissue. So that's what you're listening for. Or fluid. Dullness can be fluid too. So you do all 4 quadrants, just assessing for appropriate tympany and dullness. Now, his tympany towards the top and dullness towards the bottom is appropriate. If you get tympany at the bottom, that's okay. Not an unexpected finding. The things that would trigger you to be abnormal is if Todd had a distended belly, and I wanted to know why his belly was distended. If I listen, it sounds like a drum throughout. It's probably distended with air. If I tap and it sounds solid throughout, it's probably distended with fluid or mass. Or if Todd always has a distended belly, maybe it's Todd's beer gut, and it could be adipose tissue. But Todd will be able to tell me that. My belly's always like this, my belly's never like this, or my belly's only been like this for 6 hours. So that'll help you there. And so that's percussion. So percussion to measure the liver span. And that's when you start in the mid-clavicular line, MCL you saw on the PowerPoint yesterday. It's the mid-clavicular line. So you start there, and you percuss down, and I should hear tympani in the lungs, and eventually I will hear dullness. Tympani, like a drum. Hear that change? That's dull. So I would say here it's approximately the location of the top portion of his liver.
That's where it switches from lung to liver.
Yes. So if I had a pen, I would mark it here. So then I start lower. Tympani. It was dull, now it's tympani. 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 Dullish. Definitely dull. So I would say his liver span is approximately here, which is approximately 6 centimeters, which is normal. So you could mark it, you could measure it. If you're being extremely academic, that would be fine. Again, if you suspect any abnormality on the size of the patient's liver, you're going to order an ultrasound anyway. But this is something just to use as a diagnostic to measure to justify why you're ordering a liver ultrasound if you're suspecting an enlarged liver. So that's liver span percussion for liver span. Now there is another test that we didn't talk about yesterday. It's called a scratch test. That's what I do. Oh, there it is. So this one is also used if you don't want to percuss, or if you've got a female with large breasts and you really can't percuss because you won't get a good exam, you won't hear well. You can just use a scratch test. What that is you actually put your stethoscope over approximately where you suspect the liver to be, which so over the lower portion of the ribs, and then if your patient isn't too terribly ticklish, you kind of warn them, I'm going to scratch on your belly, and so it may be a little ticklish, but you scratch until it becomes very loud, which is in Todd approximately right here. And then you scratch from the top. And Todd is approximately right here, until it becomes right when it becomes very loud. And that's the scratch test to measure the liver span as well. It's not as accurate as percussion, but if you've got special situations where you don't really want to percuss, then that works. Now another trick that you might need to use on women with large breasts is to have them displace them themselves. So what you can say is, could you please take your arm and hook it and then push your breast to the side, and then that kind of gets this area free. So you can do that as well. Remember that the abdominal exam or any breast exams, genitalia exams can be uncomfortable for your patient. Always have a chaperone if you are a person of the opposite sex. Even if you're a person of the same sex and you don't feel like comfortable, just ask for a chaperone to come in if you're doing an exam where you think a chaperone may be required. I don't get chaperones for my abdominal exams, but I always get a chaperone for a breast exam, a genitalia exam. It just protects you, protects your patient, and it's good medicine. So whenever you're doing exams that are kind of, I'm just talking about this because we're talking about displacing breasts and all these things. Whenever you're doing an exam where your patient may feel uncomfortable, or it's an exam that's, genitalia, things like that, you want to appear, even if you're uncomfortable, which we get uncomfortable sometimes, appear as if you're not uncomfortable. So you're kind of play acting. Because if you're uncomfortable, sweaty, nervous, you're going to make your patient uncomfortable, sweaty, nervous. So try to get as much of the nerves out as you can here. That's why we practice on each other. That's why we bring models in to practice on, so that you can make your patient feel more relaxed and comfortable. One of the things that I always say when the patient says, oh, this is really uncomfortable or really embarrassing, people will say, because I've done a bazillion rectal exams, and so that's what you do, say, oh, I do these every day. I could do these in my sleep. Don't worry about it, Like, I've just done a million of these. Heck, I just did 5. So that, so you sort of like, oh, this is my job. This is my job. I'm just trying to get a good exam. So that's what you tell them. And it is your job. This is your job to get a good exam. And so to you, it's just every day. Totally, completely normal. And that makes your patient feel a little more relaxed.
Do you have a chaperone for the rectal exams as well?
Always have chaperone for rectal exams, yeah. If ever in doubt, I just ask somebody, hey, tag along if you don't mind. Or if your patient's a little squirrely, hey, do you mind popping in here with me? People don't mind to do stuff like that. They may be busy, and you may have to wait a little longer, but I always just do. If you feel uncomfortable, if your patient feels uncomfortable, any genitalia, rectal, breast exam, always get a chaperone. so that was a little sidebar. We're going to now check for the hernias, and then we're going to do the special exam. So I'm going to ask my patient to lay his feet flat. Okay. All right. Now, Todd, if you would, raise your head up and look at your toes. All right. As he's doing that, I'm observing to see if he's got any herniation in that ventral hernia. You don't. You can relax back down again. If he did, you would see the midline rise up almost like a hill. If he had any umbilical hernias, I would take my finger and I would push it down slowly to reduce it, to make sure it's reducible. All right, so now to do the special tests. And these are only done if your patient comes in with a specific complaint. You don't do this on a routine exam. So we'll start with the test for acute cholecystitis, which is Murphy's, which Todd sort of had a positive one a little bit already. But Murphy's sign is, again, almost exact same thing. When I do that, I use my fingertips a little bit more than I do the side of my hand. So I have my patient take a deep breath and I really get in there. And now, it would be positive if he stopped breathing, went ow, like this at the very top. That's a positive Murphy sign. Okay, you can go ahead and breathe. So that's a physical exam positive Murphy sign. Just as a sidebar, there's also an ultrasound positive Murphy sign, because the ultrasound probes, they really kind of dig in there too. And sometimes the ultrasound techs will report, or it will say in the report, the patient had a positive sonographic Murphy sign. So, interesting sidebar there. All right, that's the test for acute cholecystitis. We'll do the appendicitis test next. Now remember, when we're locating McBurney's point, is 1/3 of the distance between the umbilicus and the ASIS, which Todd's is right here. So it's approximately right here, 1/3 of the distance, right? If we're dividing it up into thirds, 1/3, 1/3. So it's approximately right here. That's his McBurney's point. So this is the area where patient typically report pain with appendicitis. And this is the area where you press to see if they've got rebound tenderness. So if they've got a positive McBurney's sign, that's when I'm going to tell my patient, I'm going to press in and then I'm going to let go, and you let me know which hurts worse. So I'll press in and then I'll let go like that.
Oh.
And let go. And that's a positive McBurney sign. Obturator, which we talked about in class. So I'm going to take your leg and I'm going to lift it up. If you would, please bend your knee. All right, so obturator, you take your hands. Sometimes it's difficult for girls with small hands, especially if you've got a patient with a really large or heavy leg. It can be a little hard, but you do your best. So you grab your patient's thigh just above their knee, and I'm going to rotate internally your thigh while taking my hand on the patient's lower calf and externally rotating their leg. So it starts off normal, and I do this. Very little movement, but if he had appendicitis, boy, would that hurt. Okay, so that's obturator. Everybody got that? Internal, external. Internal, external. Okay, so that's obturator. So a sign is I'm going to have my patient lay on your left side, please. So roll to your left side. Okay, now I'm going to take this leg and I'm going to move it. So literally, you just lift your patient's leg up, keep it straight. Sorry, I'm not instructing well. And then I'm going to bend it backwards. That's my patient holding on. But I'm going to bend it backwards with a straight leg. Like that. Now, again, not painful here, but if you had appendicitis, that would hurt. Okay, you can lay flat now. so it's obturator and McBurney's. Now, there's others. People go nuts with appendicitis. There's heel tap, where you take your hand and you do that. Heel jar, heel tap, and ask your patient, does that hurt? What's that doing? That's jarring, checking for peritonitis, but it's a heel tap. If you've got a kiddo, a good one to do, and kiddos get appendicitis a lot, is to have them sit up on the exam table and go, okay, now jump down, and they jump down, and oh, it hurts. So that's another way for a kiddo to test for appendicitis or peritonitis. Okay, so that's gallbladder, appendix. Let's just do rebound in general, right? So that is where, again, I'm going to press down and I'm going to let go, and you tell me which one hurts worse. So and that could be anywhere. If you're just checking for general rebound tenderness, and I'll usually test all 4 quadrants. That's it. That's rebound tenderness. We talked about the pinch and release in class yesterday. Again, we're just eliciting pain. So I wouldn't do all of those unless I was grumpy and having a bad day. Torture Todd. I want to do all of them. So if I'm diagnosing appendicitis, I'm picking one of these and I'm going with it. If I'm not sure, I'll pick a couple of them. But if I'm sure, I'll usually just document one positive. All right, so that's those. Now,
What was the flank CVA tenderness?
that one will do because you have to get your patient to sit
Oh,
up.
okay.
So you remind me of that one,
Okay.
so I don't forget. Thank you. When we're talking about ascites, when your patient's got a distended belly and you're thinking there's fluid in there, the two tests that you can do are the shifting dullness and the fluid wave. So we talked, Todd's going to be difficult to demonstrate on because he doesn't have a vertebrate belly, but imagine that you had a big vertebrate belly here. So what you would do is I would have my patient take your right hand and put it right down the midline and kind of press there for me. And I would take this hand on the side of the vertebrate belly, and I would take this right hand, and I would press like I'm trying to make a wave in the ocean, right? And at that point in time, you're feeling on this side, and if you had a ascites in a belly, you would feel a splash. That's called a succussion splash on the side of your hand and your palm. That's fluid wave. Okay, so you can put your hand down now. Now, shifting dullness is you have your patient sit up, and at this point, you know, you got a vertebrate belly, so you just would expect for with gravity the fluid to go down and the air to settle up. And so on your vertebrate belly, you would percuss. The top, hear tympany. The bottom, you would hear dullness. So then I would have my patient lay flat and on your left side. And you would expect, after the fluid settles, for to hear dullness at the bottom and tympany at the top where there wasn't before. That's the shifting dullness. So that's how you do that. All right, so I'll have my patient lay flat on his back again and sit up, and you can dangle your legs off the other. Okay, so if you're assessing for CVA tenderness, and that's again part of a special test for the abdomen, if you're considering some sort of pyelonephritis, nephrolithiasis, you assess for CVA tenderness. And I think, yeah, on the checklist, we've got that you check for it, whether it's a special test or not, so just note that. So you'll always do this for the exam purposes. Well, what you do, I'm going to lift your shirt up here, is you palpate and you feel for your patient's bottom rib, right? Which is on Todd is approximately right here. So medial to that is approximately the location of his kidneys. So you just take your hand and you tap and you jar. And that's it. And I'm pressing pretty hard here, as Todd will tell you. So that's it. That's assessing for CVA tenderness. All right, let's make sure we got everything.
So you're not trying to hear any kind of a sound with that, it's just trying to elicit pain.
Exactly. Yeah, that's not percussion.
Where you take your hand and go up and go down or something?
Yes, for assessing the spleen size, we did that one
Okay.
earlier where you have to put your hand under the left side and take a deep breath and just see if you can palpate the spleen.
Can I ask a stupid question?
Yes.
What does CVA stand for?
Costovertebral angle. That's not a stupid question. That's a very good question.
Can you
So
go back?
costovertebral angle is the location of the place where you are hitting, and that's an anatomical location. So it's approximately close to the 12th rib. That's an excellent question, Lisa. Yes.
Start to finish, 15 minutes?
Aim for 15 to 20.
Okay.
Okay. Any other questions? I think that's everything. I hope I didn't forget anything.
So that was Murphy's for the gallbladder.